Assalamu alaikum. I'm very close to my exam. Again, I'm giving endocrinology. Today, I would like to talk about some things about endocrine. Starts with this myxedema coma. Myxedema coma is a medical emergency. Is a medical emergency. It's a very rare presentation of the hypothyroidism in which there is depressed level of consciousness. Usually in the older patient who appears myxomatous, body temperature is very low, low as 25 degrees Celsius. Body temperature is very low, 25 degrees Celsius, and convulsions are not uncommon. Convulsion, very low temperature, and CSF pressure and in CSF pressure and protein are raised. In here motility rate is very high and survival depends on the early recognition and the treatment of the hypothyroidism and contributing to the altered consciousness level such as medication, cardiac failure, pneumonia, dilution of hypothyroidism and respiratory failure. Myxedema coma is a medical emergency. The medical emergency treatment begins before the biochemical confirmation of the diagnosis. Suspected cases should be treated with intravenous injection of 20 microgram leothyronin followed by further injection of the 20 microgram 3 times daily until there is sustained clinical improvement. In survivors, there is a rise of body temperature within 24 hours, and after 48 to 72 hours, it is usually possible to switch a patient to oral levothyroxine in a dose of 50 microgram daily. Unless it is apparent that the patient has a primary hypothyroidism, the thyroid failure should be assumed to be secondary or hypothalamic disease and treatment given with hydrocortisone 100 milligram hydrocortisone 100 milligram intramuscularly daily 3 times daily pending the results of T4 and TSH and cortical measurement. Other measurement is skin rewarming, cautious use of IV fluid, antibiotics, and high flow oxygen. So treatment depends on four things. In here, IV leothyroid, IV injection of 20 microgram leothyronin, IV injection of 20 microgram leothyronin, followed by further injection 20 microgram 3 times daily until there is sustained clinical improvement. In survivors, there is a rise in body temperature within 24 hours. After 48 to 72 hours, we can shift to oral levothyroxine 50 microgram daily. We can give IV hydrocortisone 100 milligram IM 3 times daily, pending the results of the T4, TSH, and cortisol measurement. And other measure include slow rewarming, cautious use of IV fluid. Broad spectrum antibiotic and high flow oxygen. Broad spectrum antibiotic and high flow oxygen. What is the ultrasonogram characteristics of the benign nodule? It is hypo. In benign nodule is iso hyperechoic spongiform, smooth border or halo, thin cyst wall, dense calcification, but microcalcification, irregular border, hypoechoic, and increase intranodular vascularity, and tall than wide, increase intranodular vascularity, tall than wide. Okay, next Next thing is Graves' ophthalmopathy. What happens is in Graves' ophthalmopathy, the pathology is this condition is immunologically mediated with TSH receptor identified as the TSH receptor identified as the main autoantigen. It is immunologically mediated with the TSH receptor as the main autoantigen. Within the orbit, the dermis, there is cytokine mediated proliferation of the fibroblasts. They secrete hydrophilic glycosaminide. They release hydrophilic glycosaminide. These resulting in increase in interstitial fluid content. These result in increased interstitial fluid content and combined with a chronic inflammatory infiltrate. Cell infiltrate causes marked swelling and ultimately fibrosis of the extraocular muscle. Fibrosis of the extraocular muscle and a rise in the retrobarbular pressure. The eye is displaced forwards. Proptosis, exophthalmos, and in severe cases, there is optic nerve compression. There is optic nerve compression. Ophthalmopathy like thyrotoxicosis typically follows an episodic ophthalmopathy like thyrotoxicosis typically follows the episodic course, and it helps to distinguish the patient with active inflammation, periorbital edema or conjunctival inflammation, changing the orbital sign from those in whom with inflammation of the burned out. Eye disease is detectable up to 50% of the thyrotoxic disease at presentation, but active ocular inflammation may occur before and after the thyrotoxic episode. Exophthalmic grave disease. Ophthalmopathy is common in men and cigarette smoker. It may be exacerbated by the radioiodine. It may be ophthalmopathy may be exacerbated by the radioiodine therapy and poor control of the thyroid function, especially hypothyroidism. Poor control of the thyroid function, especially hypothyroidism. This is high yield. The most frequent presentation symptoms are related in exposure of the cornea resulting in proptosis. There may be excessive lacrimation made worse by wind and bright light, a gritty sensation in the eye, and pain due to conjunctivitis or corneal ulceration. In addition, there may be reduction of the visual acuity and visual field as a consequence of the corneal edema or optic nerve compression. Optic nerve compression. The majority of the require no treatment, and their reaction is smoking cessation, uh, oral selenium can be given 100 microgram twice daily for 6 months. In patient with mild Graves ophthalmopathy, you can give oral selenium. Improves the quality of life, reduce ocular involvement, and slow the progression of the disease. The mechanism is not known. Moderate to severe ophthalmopathy, multidisciplinary approach, more severe inflammation, glucocorticoid, that is pulse intravenous methylprednisolone, or orbital and sometimes orbital radiotherapy. In recent evidence emerged support the use of immunosuppressive rituximab, tocilizumab, and IGF receptor can be given in Graves' ophthalmopathy. Loss of visual acuity is an indication for urgent surgical. Loss of visual acuity is an indication of urgent surgical decompression of the orbit. In burnt out disease, surgery to the extraocular muscle and later eyelids and may improve diplopia, conjunctival exposure, and cosmetic cosmetic appearance. So, what are the thing I am discussing in Graves' ophthalmopathy? This is very important. This is a must know actually. I missed something. In Graves' ophthalmopathy, it is this condition is immunologically mediated with TSH receptor identified as the main with the TSH receptor identified as the main autoantigen. TSH receptor identified as the main autoantigen. Within the orbit, there is cytokine mediated proliferation of the fibroblast. Cytokine mediated proliferation of the fibroblast that secretes hydrophilic glycosaminoglycans. These the resulting increase in interstitial fluid content combined with chronic inflammatory cell infiltrate causes marked swelling and ultimately fibrosis of the extraocular muscle and a rise in the retrovalvular pressure. The eye is displaced forwards and in severe cases there is optic nerve compression. There is optic nerve compression. So this is the thing for Graves' ophthalmopathy. And the next thing in subacute thyroiditis, in transient thyroiditis, there is subacute thyroiditis, there is postpartum thyroiditis. In classic form of uh, classic painful form of subacute thyroiditis, transient inflammation. Classic painful form subacute thyroid transient inflammation of the thyroid gland occurring after infection of the Coxsackie, mumps, and adenovirus. Mumps and adenovirus. There is pain in the region of the thyroid that may radiate to the angle of the uh, pain in the thyroid that may radiate to the angle of the jaw and ear. It uh, it may worsen swallowing, coughing. It may worsen swallowing, coughing, and the movement of the neck. The thyroid is easily palpable. The thyroid is easily palpable and large and tender. Systemic upset is common. Affected patient is usually female, 20 to 40 years. Painless transient thyroiditis can help after viral infection. The condition can be precipitated by the drugs interferon alpha and lithium actually worsens the condition. Subacute thyroiditis can be worsened by this condition can be worsened by interferon alpha and lithium. Irrespective of the pain is symptomatic, simply measured NSAID can be given. Occasionally, we use prescribed prednisolone 40 milligram daily for 3 to 4 weeks. Prednisolone 40 milligram daily for 3 to 4 weeks. The thyrotoxicosis is mild, and the treatment is with a beta blocker. A beta blocker is usually adequate. Antithyroid drugs are of no benefits because thyroid hormone synthesis is impaired, and carefully monitoring of the thyroid function. So beta blocker is the treatment. We can use beta blocker. What happens? Inflammation of the thyroid gland associated with the release of the colloid and the steroid thyroid hormones, but also with the damage of the follicular cell and impaired synthesis of new thyroid hormone. As a result, T4, T3 levels raised 4 to 6 weeks until preformed colloid is depleted. Thereafter, there is a period of hypothyroidism of variable severity before the follicular cells recover and normal thyroid function is restored within 4 to 6 months. Normal thyroid function is restored within 4 to 6 months. In the thyrotoxic phase, iodine uptake is low because the damaged follicular cells are unable to trap iodine and because TSS secretion is suppressed. Low titer of the thyroid autoantibody is transiently low in the serum. The ESR is usually raised. High titer antibodies suggest that autoimmune pathology and greater risk of recurrence, ultimately progression to hypothyroidism. Progression to hypothyroidism. In postpartum thyroiditis, which is modified during pregnancy to the survival, allow the maternal immune response, which is modified during pregnancy to allow the survival of the fetus and is enhanced after delivery, may unmasked previously and recognized subclinical autoimmune thyroid disease. Within 6 months of the delivery, usually develop within 6 months of the delivery. Those who are affected likely to have anti-TPO antibody present in early pregnancy. Symptoms of thyroid dysfunction are rare. However, symptomatic thyrotoxicosis present for the first time within 12 months of the childbirth, likely due to postpartum thyroiditis, and the diagnosis is confirmed by negligible radioisotope in uptake. The clinical course and treatment is similar to those with painless acute subacute thyroiditis. Painless subacute thyroiditis and eventually progress to over a period of years to permanent hypothyroidism. Okay, in Hashimoto thyroiditis, in chronic autoimmune thyroiditis characterized by destructive lymphocytic infiltration of the thyroid gland, ultimately leading to varying degree of the fibrosis and thyroid enlargement. In here, anti-TPO antibody is present. 90% with Hashimoto thyroiditis, there is increased risk of lymphoma. This is held that in Hashimoto thyroiditis there is thyroid increased risk of thyroid lymphoma. Levothyroxine therapy is indicated as treatment for hypothyroidism, also to shrink the associated goiter. In context, the dose of the levothyroxine should be sufficient to suppress the TSH to low the detectable level. Okay, malignant thyroid tumor, malignant papillary is most common. Papillary follicular, then anaplastic papillary, then follicular 10 to 20%, then anaplastic less than medullary 5 to 8%, and lymphoma less than 5%. Lymphoma less than 5%. The goiter black arrow, the goiter causing acute severe and the stridor due to tracheal compression. Stridor due to tracheal compression. The goiter is causing acute severe breathlessness. This is all about important things about thyroid. Hope you like.